Well, thank you very much for inviting me to come and speak to you. And I'm going to talk to you about Flab, or fat, fact and fantasy. And what John North has just presented to you is some gross figures about obesity. And we're going to have to try and work out where the fact and where the fantasy is in all this. So, first of all, I'd like to say that in the Courier Mail a few months ago, you may remember this front page where the people were encouraged to move to Queensland, and if they wanted to be healthy, they shouldn't smoke, shouldn't be overweight, be a workaholic. If you're a male, you're supposed to have a partner because that's better for you, and don't retire too early, etc., etc. And I just want to say that John North is probably one of these people that's managed to live his entire life and avoids the scourge of putting on any weight. I don't know how thin you were before, John, but thank you very much for inviting me. Now, I do need to declare a conflict of interest, because at the start of this meeting, I did actually check my BMI, and I have slipped over the years from being normal weight into just being in the overweight category, my BMI being 27. And so I now have much more interest in this subject, and therefore I must say to you, maybe I have some bias. But there's a lot of noise about obesity, and a lot out there, and I think we've got to make sure that we don't make false claims, and we don't stigmatize people, even though it's a very good idea to be slim and healthy. So the sort of questions that I hope to be able to answer with you, or at least help you on the road to answering them, because they can't all be answered, is these are some of the statements that are around today. There is more obesity in society than ever before. More patients are dying who are obese than 10 to 15 years ago. Patients who are overweight and obese have a higher surgical morbidity and mortality. Surgical mortality rises with the level of our degree of obesity. And patients requiring elective surgery should be encouraged to lose many kilograms of weight before they get their operation. I think you'll all have heard those things said. How many of them are true? I hope we'll be able to answer some of these. Let's accept, first of all, that Australia is unfortunately following the US as a very fat nation. And why? Because 30 to 40 years ago, sugar and corn syrup got off scot-free and fat got targeted. And I think anyone who is a student or studying diet today realizes that fat was not the problem, but fat got blamed, and therefore the food manufacturers were able to put loads of sugar and sweet stuff that made things taste good into our food. And for 30 or 40 years, people have consumed that. And if you eat processed food, then it's been designed to, in fact, taste good and even sugar addict people. So that will have to change in the future, but that's really cause and not what we're talking about today. But all of these are factors in why we are, in fact, evolving, or indeed is this part of development that as we go from Neanderthal to modern man or woman, we become like the Coke-carrying, hamburger-eating, processed food disaster at the end of the evolutionary chain. And many of us haven't even got the genes that were designed to be eating every day and too much. And certainly not only are 27% of Australians obese, but the mean BMI has increased over the last 30 years from 24 to 28 kilograms per meter squared. So there is a problem, there's no doubt about that. And the Courier Mail, again, my source of all things that are true, Queensland is the fattest state, and there is the evidence. 30% of Queenslanders are obese. Now, it's a problem all around the country. The figures aren't actually very much different, but there you are. But now we need to ask ourselves, yes, I used that word flab. Is flab such a bad thing? And does flab actually compare with being really fat? There is, in fact, a J-shaped curve for BMI, and the least healthy people may, in fact, be the thinnest people. John, I think you make it into the normal weight. You don't need to worry. But it's actually not good to be really thin. And in population studies, some of the reasons for that may be that people who get measured are actually losing weight from cancer, some are anorexic, some are smokers, some have lung cancer. But undoubtedly, there is a J-shaped curve. So in fact, I'm very reassured about this, and again, I declare my conflict of interest, but you can see 27 is just right down at the bottom of that J-shaped curve. And the other thing is that 30 years ago, a large population study showed that people should gain 2.5 kilograms per decade after the age of 40 if they're going to be really healthy and have the lowest mortality outcomes. So you can take that, that's actually in a very good journal. So the question is, does body mass index affect survival? Now, the Lancet has reviewed 57 studies and 900,000 individuals. And the best survival was people who actually had normal weight of 22 to 25. And the mortality hazard was an extra 1.29, so 0.29 extra, 29%, every 5 kilograms per square meter gained. And the sort of conditions that were affected by putting on BMI were vascular diseases, and you can see a large increase if you put on weight in diabetes, renal, and hepatic diseases. There was an inverse survival with people who were thin, below 22.5, and most of the studies that I've read in surgical journals and others would be below 18.5. And if your BMI is 30 to 35, you have 2 to 4 years less survival. If your BMI is over 40, in other words, you're morbidly obese, then that's associated with 8 to 10 years less survival. So, and the effect of being morbidly obese above 40 is comparable to the smoking effect. So, looking at the best evidence, and given that this is a 2009 study and there haven't been any that have refuted it since, I think that we can say that, in fact, there is no doubt that if your BMI is too high, you will have a lower survival. Now, I was very interested in the fact that John was using the word obese, but I would like to say to you that, in fact, the word obese covers probably many sins and perhaps a few good things. And we have to realize that there's a whole range of being overweight to being obese to being morbidly obese, and make sure that we know what we're talking about, which is why it would be so important to put BMI into future QASM studies. But again, here is the J-shaped curve for both men and women from that Lancet article, showing you that, in fact, BMI does affect survival, but it's a J-shaped curve and not a linear one. And there are, in fact, some paradoxes, because people with heart disease, their survival is actually related to their body mass index. But you can see here that, in fact, there's low-weight people do much worse, and these ones do much better. And here is survival with heart failure over a period of 2 years. And you'll see that, in fact, obese people actually do better than people of normal weight. And so we're not quite sure, but this is what's called the obesity paradox. So before we actually target obesity, we need to realize that there may be other factors at play. It may not simply be body mass index. Cardiologists suggested this may be the adipose tissue provides nutrients for the heart in times of need in ketotic metabolism. But whatever it is, you can see that there is, in fact, also an obesity paradox to consider. So what actually predicts that people who are having a surgical operation might actually be at risk from obesity? And are those two patients, the one in the yellow shirt and the red shirt, the same? Well, there's no doubt that body mass index actually increases your blood pressure, and it reduces your HDL cholesterol and increases your non-HDL cholesterol. So it's clearly bad for what's going on in your cardiovascular system. And the reason really is that some people who are obese actually have metabolic syndrome. So they have heart disease, lipid problems, hypertension, type 2 diabetes. They're more likely to get dementia, cancer. They're more likely to have non-alcoholic fatty liver disease, or if they're female, polycystic ovarian syndrome. So those people are undoubtedly actually unwell and at risk from the operations. But there's a whole category of obese people who do not have metabolic syndrome. And we actually really need to think that we need to identify which of our high BMI patients actually have metabolic syndrome and those that don't. So we can measure the waist circumference, their triglycerides, their HDL, their blood pressure, their glucose, and identify those people who are higher risk, because there's very little evidence at all that if you don't have metabolic syndrome, your outcomes are actually worse. And this is going to make it even more challenging to, in fact, study effectively the influence of obesity and high BMI. So the question that many people would like to ask is, what problems does obesity cause? Obviously, if you actually die, there's a large problem with actually, for the pallbearers, of actually getting the coffin into the grave. But does obesity actually cause surgical mortality? And this was recently addressed in the West Australian Audit of Surgical Mortality. But I would like you to consider, first of all, some of the facts of the matter. The facts of the matter are that the number of surgical mortalities in Western Australia are falling. And the mortality rate per 100,000 population is also falling. These are the columns here. So there's no doubt that surgical mortality is dropping in Western Australia. There's no doubt that in Western Australia, 10% of people who die actually have obesity marked on their WASM form, similar to what comes on the QASM form, even though about 26% of the Western Australian population are actually obese. There's no doubt that the incidence of obesity, as marked by surgeons on the case record form, has been increasing since the WASM began auditing surgical mortalities in 2002. And this has gone from about 2, 3, or 4% all the way up to the 9 or 10% of today. There's also no doubt that the incidence of diabetes has been rising following the same pattern as a comorbidity with obesity. And we all know that BMI and diabetes are related. The newspapers picked this up, and this is what was reported. Obesity is contributing to an increasing proportion of deaths on the operating table. Well, maybe it's associated with an increasing proportion of deaths in surgical patients, but the operating table was a little bit far-fetched. I like the headline, though, that in the West Australian, surge and obesity-linked surgery deaths. That was really clever alliteration. Fewer people overall are dying in hospital during operations, according to the West Australian Surgical Mortality Audit. Definitely true, definitely fact. Number of patients dying has risen from 2.5% of surgical deaths to 10%. That's of people with obesity. Well, that's actually true. That's an association. But given that the number of surgical deaths has been going down and the number of obesity-associated deaths has been going up, you can actually conclude one of two things. Either obesity is actually reducing the mortality, or it might be increasing the mortality. But you could choose either if you were a reasonable scientist. And, strong statement here, this strongly suggests that lifestyle issues contribute to riskier surgery and that this observation needs to be seen against the increasing public health issue of obesity. Fact that obesity is a public health issue. Fantasy that this actually strongly suggests that. So let's see what's happening. What's happening to perioperative mortality around Australia? Well, perioperative mortality rates are dropping all around the country. So this is in fact data that's still unpublished, but from AIHW that the college has got, showing that the perioperative mortality in the last 4 years has dropped to 0.36 for public hospitals. And at the same time, the number of procedures having an operation have been going up all across the country. And I'm very aware that I'm in Queensland, where you've got the best low waiting list patients and lack of long waiters on your waiting list than any other state in the country. And you are definitely an excellent performer at doing more operations. And Australia-wide, we're doing in public over 4,000 operations per 100,000, never mind the 60% of elective operations that are done in private. So these are all very good figures. And in fact, if we just look at Queensland's figures over here, you'll see that the number of operations has been going up and the number of mortalities has been going down, and the perioperative mortality rate for public and private combined now has been going down in Queensland as it has across the country. So there's no doubt that the Western Australian drop in surgical mortality is reflected all around the country, and that's a fact. What influences surgical mortality? The strongest influences of surgical mortality are age and urgency. And this is a graph showing elective mortality here, and it shows that when we decide to operate on over 80-year-olds, they usually survive. When we have to operate on over 80-year-olds as emergencies, they have a higher mortality rate, although the mortality rate is still a very respectable 5 or 6%. So, does body mass index actually affect surgical outcomes? That's what you're all here to ask me to talk about. And this is a study using the NESQIP data from the USA of 141,000 patients that were undergoing 16 really major procedures. And I'd like you to look first of all at the perioperative mortality rate. And this is gradating the BMI because NESQIP has the actual BMI. But you'll see that the group with the highest perioperative mortality rate, and obviously there are apples and oranges in this, but it's all major surgery, 3.5%, and then, in fact, very acceptable perioperative mortality rates, very acceptable complication rates with a rise in the morbidly obese, with particularly wound infections having a significant rise. And I've highlighted these ones that are actually statistically significant differences, and reintervention rates staying low across the range from normal to morbidly obese, but reintervention rates being high in the underweight, and readmission rates being highest in the underweight and being pretty steady in the... So does a high BMI cause morbidity? Yes, particularly to the wound. Does it cause mortality? Well, that's actually a little bit harder to say, and you would actually say that it's worse to have a low BMI than to have a high BMI. This paper was published in the ANZ Journal of Surgery this year, a meta-analysis of only 4 studies that measured visceral obesity using CT scanning, but I think this is a study that could easily be repeated anywhere, and I would encourage some people to repeat this, but the increase for colorectal outcomes or colorectal surgery if you had high visceral obesity, you're more likely to have to convert from laparoscopic to open, longer operative time, less lymph node harvest, higher morbidity, and a higher anastomotic leak rate. And they didn't happen to mention mortality in that paper, which is rather disappointing, but I wasn't reviewing it. And BMI and abdominal cancer perioperative outcomes. Here's a study from the Annals of Surgical Oncology showing over 2,000 patients with those particular cancers up here. And there was an overall morbidity increase with BMI going from 21% up to 32.9% morbidity, and with the highest increase due to BMI being in the wound. And if we actually looked at the mortality rates, though, there was a reverse J-shaped curve where the underweight did by far the worst, and then it really went down to the obese level and then started to rise until you got to the morbidly obese over 40. So actually, what this paper is saying is these are people who all needed to have surgery. These are not people who you could say, come back when you've lost 10 kilograms in weight or 20 kilograms in weight. These people had to have surgery, and yet the overweight, the obese, and the obese 35 to 39, class 2, actually all had very good surgical outcomes in that particular study. So I don't think it's actually true that most people who are obese, until you at least get to morbidly obese, actually have a higher mortality, even though you're more likely to suffer wound complications. And because I'm from Geelong in Victoria, I did want to show you that we are starting to look at BMI in our colorectal patients, and this is rather a complicated table for an audience to look at. But again, if you just look at the perioperative mortality rate for colorectal operations, this is acute and elective patients, you'll see that the people who were obese and morbidly obese actually didn't die. They did have some complications, but no more complications than any of the other groups. And we can't see any difference with our low numbers at the moment, but 288 patients is more than that 4-study meta-analysis on visceral obesity that I showed you. So the facts of the matter are that BMI is not good for long-term survival in a healthy person. If you're sick and you need surgery, you're going to get a good outcome if you're overweight, if you're obese, but you may have higher wound complications, and if you're morbidly obese, you may have a higher mortality and higher wound complications. What do we need to say to our patients? We need to say to our patients that if you're going to have an elective operations, you need to go into prehab. And that means doing exercise and losing a few kilograms of weight, because the evidence shows that if you're obese and you lose 2 or 3 kilograms in weight and you exercise for a couple of months before your operation, you will actually have a very much better outcome. And I think most of the best work in that has been actually done in joint replacement surgery. And just because you can't use your knees or your hips doesn't mean to say you can't sit down somewhere and make your arms do the work. And for someone like me who wrecked my knees with ultramarathon running when I was overseas, at least that I can box my way to old age, hopefully healthily, and when I need my surgical operations. So I think this is the message that we need to give to people. If you're obese, you don't need to, in fact, lose 20 kilograms of weight. You need to do a little bit of prehab, and we're likely to give you a good outcome. The college is actively advocating on the topic of obesity. We're advocating on the reasons why people get obese and the health implications of being obese and having a high BMI. And we're also, and the importance of whether or not you've got metabolic syndrome in non-bariatric surgery. And we're also advocating very strongly for people to have access to bariatric surgery in the public system, because all of the evidence would show, and that's not my subject today, that access to bariatric surgery actually works in bringing down BMIs and dealing with the issues of the development of metabolic syndrome and all its complications. And if we're going to offer bariatric surgery in private, we should not exploit or extort our patients in the gap fees that we charge. And so the college is activating very strongly on that too, that fees should be reasonable and not take advantage of the patient. And I've been quoted in the newspapers this week on behalf of the college saying that no one should ever have to access their superannuation or remortgage their home in order to get private surgery. That's really quite unethical, and I'm very happy to say it again. It's been very interested too that that's been tweeted more often than most things that the college says, and so I really hope that message gets out. But thank you very much for inviting me to speak on Flab, Fact or Fantasy.